Okay, great. Good afternoon, everyone. I think we'll go ahead and get started. My name is Nathan Blanchet. I'm a program director with Results for Development and have served as a senior health economist on the HFG project. I'm delighted to be here with you today. It's been many, many years since I've been in this building, and I don't think I've ever been in this room, which is a beautiful one. So I'm glad we got this one for our session. And I'd like to welcome all of you as well as my panelists, Kerry Pelzman from USAID, and Catherine Connor and Stephen Musau from Apt Associates. I'll say more about them in a minute. So today our session for the next hour is focused on the topic of preparing countries for transition. If you were with us this morning, you'll know that this topic has already kind of come up several times, and hopefully we can dive into it in even more detail in the next hour. So what we will do is I will provide just some brief framing comments about this topic and a little overview, and then we're going to turn to our distinguished panelists and have a Q&A with them, and we will be focusing especially on the experiences that they have all had in South Africa and Botswana. And I promise, with Laura's help, to save at least 15 or 20 minutes at the end of our session for a broad discussion and Q&A. And we really mean that, so please do be preparing your thoughts on transition, your own experiences working on transition, and any questions that you have for the panelists. Okay, so let's just start briefly. I think it's worth pausing for a minute and making sure we're all thinking about this in the same way. What do we mean by transition? It's a quite familiar term, and yet we know that there are lots of different kinds of transitions, and it can mean different things in different contexts. Most of us work in the field of public health and are probably familiar with the demographic and epidemiological transitions that countries are typically going through. Typically, the pattern is you see countries going from high death and birth rates to low death and birth rates, and alongside that demographic transition, change is really in the burden of disease. The classic story is one of a shift from infectious diseases to more chronic diseases, but as I'm sure you all know, that classic story doesn't always happen, and you may have countries developing quite serious problems with a dual burden of disease, where infectious diseases are still an important part, along with rising diabetes, hypertension, and other chronic diseases. So as public health people, we have these kinds of transitions in our minds, of course, on top of macroeconomic and political transitions that countries may be going through. But I suspect you all know that it's really the health financing transition, and particularly in the past decade or so, this transition toward universal health coverage that many countries are trying to achieve. And that one is one that we see countries trying to move, as they get wealthier, away from two sources of funding for health: external funding and also funding that is coming directly out of pocket at the point of care. And this graph that you see is a nice stylized sort of version of these transitions going on in health financing. And I'll thank Ajay Tandon from the World Bank for letting me borrow this. If you focus on the blue line there first, you see a quite robust relationship. As countries are getting wealthier, their GNI per capita on the x-axis there is going up. We do tend to see higher total health expenditures. But then the other two things that I just mentioned are also displayed on this graph. We expect that as countries move from lower income to higher income, that the share of external funding of their total health expenditures will be dropping, that purple dotted line that you see, and also that the out-of-pocket spending shown by the red line will be dropping. And we'll come back to this and see where the two countries that we're focusing on in this session are. So it's really that purple line of the external share, the transition away from external funding, that is our sort of narrow focus today. But even that has kind of different flavors to it. You might say that sometimes we are all working on a quite acute challenge of transition. I call it acute in situations where you have perhaps a particular donor-funded program, often a vertical program that's dedicated to one disease or health condition, and there may be a shorter-term sort of urgency about transitioning away from that funding. But you also often at the same time have a broader transition going on, as you see in a country like Ghana, for example, today. The new president has actually made quite a public declaration and strategy for the country to move Ghana beyond aid, this broader transition of really moving all their health needs away from a reliance on external funding. And we heard Kelly Saldana talk about this being a priority for AID as well this morning. So that is where our focus is today. And why is this important? I think, first of all, we have sort of combination of clear problem and clear opportunity. The clear problem is fairly obvious. This decline in donor funding in places puts some very important health services and people at risk. But it is not just a negative story. We think that there's also a positive story, a very clear opportunity to use that pressure that comes from the move away from external funding to do good things. And those good things can be pushing reforms that make health systems more efficient, more effective, more equitable. The final reason I think it makes sense for us to all talk about this together is that there's no easy answers here. There's certainly not a one-size-fits-all. This is not a case of having some very clear technical best practices that we look up to the WHO to issue or something like that. This is really something that we all need to talk about, I think, learn from experience, and continue working in the future, governments, donors, implementing partners, to figure out how to do this well. There are several challenges and opportunities in transition, and we're going to hear about some examples of these from the two countries. First and foremost, you have the basic problem of replacing, and also not just replacing, but often expanding funding in the future through either domestic resource mobilization and or creating efficiencies in the system. I say expanding funding in the future in the case of, for example, HIV. You may be worried about current donor funding being replaced, but also the country may very well have targets that it needs to hit, which will require a much larger expansion of funding. So these are going on at the same time. We heard some great examples this morning, one from Vietnam, about the need to create new institutional and governance arrangements. So we'll get into that. That's another big challenge. That can require changes to public financial management systems and perhaps new ways of channeling money, let's say from a public purchaser to private providers for the first time. Can be another new requirement. We want to make sure that there are systems in place to monitor and ensure continued progress, especially for priority health areas and especially for vulnerable groups whom we might worry about the most in the future. All of this requires the very difficult task of aligning donor priorities and requirements with countries' existing systems and future plans, keeping in mind that those systems, as we talked about, are in a constant state of flux and changing and going through many transitions. So the lesson here is this is hard, but we've got a lot of smart minds in the room. We've got really good experience, and we think there's a real important opportunity here. So we're going to focus on this question, and hopefully we will all walk away with at least one principle or best practice or some key takeaway about how what principles we should apply to guide donors and their partners in helping countries prepare for transition. Okay, so we're back to this graph, and I have added two little flags there for South Africa and Botswana, mapped against against that blue bar. You can see these are both upper middle income countries. They are about where one would expect them to be based on this graph in terms of their GNI per capita mapping out to total health expenditures per capita that are right around $400 for both of them. The two countries actually have quite low out-of-pocket share and external share of funding already. All of those indicators are under 10% for them, the external share and the out-of-pocket. And I just want to pause on the external share thing. South Africa's is quite low. It's about 2.5% only. I say only, but as we're going to hear about, just that 2.5% may be in areas where there are still quite critical transition challenges, even when you get to that low stage. So as countries are going along this path, we've got a lot of work that we think we can do and help countries to do this, and we want to hear now more from our panelists. So without further ado from me, I have the great pleasure of introducing our three distinguished panelists. First, we are very lucky to have the Deputy Assistant Administrator for the Global Health Bureau of USAID, Kerry Pelzman. Thank you, Kerry. We're especially lucky to have her because she has quite a rich set of experience from different mission contexts, having served in Russia and Central Asia in a time that whole region was going through transition, Iraq and Afghanistan, and conflict zones, and two upper middle income countries, India and South Africa. So really thank you for joining us, Kerry. And next we have the Deputy Director for the HFG project, the Principal Associate in International Health at Abt Associates, Karen Connor. Oh my gosh, sorry. I got my Kerrys and my Catherines. Catherine Connor, my good friend, to whom I report on the HFG South Africa activity.
Used to.
Wow. All right, so Catherine has been country manager for HFG South Africa activities, among many other things. And finally, we have HFG's Public Financial Management Advisor and also the country manager for HFG activities in Botswana and Namibia, Stephen Musau, is a Principal Associate at Abt Associates. Thank you for joining us, Stephen. All right, great. So let's get you guys started. And I would first like to ask the same question to all three of you. We're going to talk about South Africa and Botswana. Please just take us to those countries and give us a little bit of the context that you faced there or indeed are still facing as it pertains to transition. Kerry, let's start with you.
Thanks, Nathan, and many thanks to the organizers, to HFG, for this event. And I'm sorry I'm only able to join you for this session. I want to start by acknowledging, as Nathan did, there are a lot of very smart people in this room, including many mentors and colleagues I've had the privilege to work with over the years. So I look forward to your responses to some of these questions as well. I came back from South Africa to headquarters about 5 months ago, so obviously the landscape has changed. But the program is unique in many ways. It is one of USAID's largest programs funded through the President's Emergency Plan to Fund AIDS Relief, or PEPFAR. As many of you know, South Africa is the epicenter of the HIV epidemic, and it was clearly a priority for the U.S. government as well as for the government of South Africa to control the HIV epidemic there. In order to facilitate our global efforts towards controlling HIV epidemic. Similarly, South Africa is one of the high-burden countries for both tuberculosis and multi-drug-resistant tuberculosis, and South Africa is one of 10 countries in the U.S. National Action Plan to combat multi-drug-resistant TB. So there were those two major health challenges and public health challenges that the U.S. and USAID were there to address. We did this obviously very much in partnership with the host country government. As Nathan mentioned, we usually said South Africa was funding about 85% of the HIV response, with the balance being made up by both PEPFAR and the Global Fund to Fight AIDS, Tuberculosis, and Malaria. So a lot of U.S. government and, thank you, American taxpayer investment in the country. So the context was one in which we were working closely with both the National Department of Health, the National Treasury, the presidency, the highest levels really of the government of South Africa to respond to the epidemic, build capacity, and ensure sustainability of the response. Now, there had been a 5-year partnership plan established which very much echoed the graph Nathan put up, where The USG resources were to decline over the 5-year period, while the government of South Africa's investment was to invest. And we were well on that course, and HFG helped us in our work with the National Department of Treasury. Concurrently, the national government was embarking on something called the National Health Insurance Program for universal health coverage, and I think Catherine will probably speak a little bit more about those specifics. So we were looking at how do we ensure the funding that we negotiated would come from the government of South Africa to support the response continued, and we still had that political will and leadership and funding, as at that point the U.S. was transitioning out, and yet we still needed to ensure that HIV was being addressed and TB while they were embarking on this broader health sector reform and health financing initiative. So that kind of provides the context. I will say, if I may, one of the other key features in South Africa was the exceptional leadership we had from the government of South Africa. And if every country had a Dr. Jürgen Pillay, we would all be in a very different place. Similarly, having great partners helped, and having great staff. So really, some of my team members should be up here. But I think I'll stop there and let Catherine add.
And the segue that you started making, I think, is a good one to Catherine, to maybe focus in a little bit on the context that the project found when we started there.
Absolutely. So the objective of HFG in South Africa was to do just what you said, is to assist the country to prepare for a transition away from donor funding, but to sustain, if not expand, their HIV/AIDS program so they could achieve the 90-90-90 targets. So the challenge for us as an implementing partner was to be responsive to the government, to government requests for assistance, the National Treasury and the National DOH, but make sure that we are, clearly contributing to PEPFAR goals, because we're funded entirely by PEPFAR. So we need to really have a clear line of sight between our work and PEPFAR's priorities. And so we found that opportunity by working with National Treasury and NDOH on their National Health Insurance Program and on domestic resource mobilization, and focusing on the integration of HIV/AIDS in those two areas.
Great, thanks. So thanks for that sort of setting the stage in South Africa. Let's do the same, Stephen, in Botswana.
Yeah, thanks, Nathan. Just to begin with, in Botswana, to mention that HFG's focus has been on health financing, not so much on the governance, but just on the health financing. One other thing about Botswana, I think we all know that Botswana is an upper middle income country. It's got quite good, fiscal management of its economy. And one thing about that is that the health sector has benefited and is actually very well funded. Unlike many other countries in Africa, where we go and, the cry is always, the health sector needs more money. Botswana is kind of different, that the health sector is actually quite well funded. But despite the good funding available to the health sector, you find the same kinds of challenges that you would get in low and middle income countries. For example, the absence of good data on which to base decisions. There was no health financing strategy to guide, investments in the sector. And one other thing that has been pointed out by many people in the country is just the inefficiencies within the health sector. Lots of duplication and just many glaring inefficiencies that needed to be addressed. So that's kind of like the context within which we started our work.
Okay, excellent. Thank you very much. Hopefully that gives a picture to everybody of sort of the situation that was found in South Africa and Botswana. So let's dive in a little bit more. Kerry, I'll come back to you. You were talking about the quite high-level dialogue that was needed to have with South African government. Can you tell us sort of more about that, the situation that you you and your team had in the health office of the USAID mission, and how you approach that dialogue with the government.
Sure. Actually, part of the establishment of this 5-year partnership framework implementation plan was the creation of different governance structures. And those were ideal in some ways because they enabled us to have this high-level dialogue. The steering committee was co-chaired by the Minister of Health and the U.S. Ambassador to South Africa. The management committee, and that met basically twice a year to sort of approve major decisions we were taking. The management committee, which met more often, typically quarterly, was co-chaired by the deputy president's social advisor and the PEPFAR coordinator in country. And so there were structures created, and both of those committees involved multiple ministries or departments, as they're called in South Africa, around the table. So we had engagement from those different sectors, since we were trying to emphasize that this wasn't just a health issue, and clearly the Department of Treasury was key. So part of it was creating those structures to oversee the program in general, and similarly, the donor coordination that took place provided another way to reiterate or echo the messages from PEPFAR and the USG. So the country coordinating mechanism for the Global Fund was another illustration. But then, part of the role of the implementing partners that proves so crucial is that they have specialists and advisors who can also sort of be implanted within the government or embedded in the government, or provide really valued counsel and inputs over time to the different parts, particularly in this case, the Department of Treasury. And I think establishing that relationship and working very closely with Treasury probably was one of the hallmarks of how we were able to make the progress towards transition that we did in South Africa. I think.
Yeah, great. So sort of, again, a little segue. Catherine,
I'm afraid she answered my question.
No, but I think
I could come up with something else.
No.
I won't let you get away with that.
No.
But specifically take us then to HFG,
Yeah.
and you just mentioned the team in Treasury that we worked with, et cetera.
So I was going to say, like, if you were asking about the approach that we took, it does begin with the mission. Like, I would totally give credit to the USAID mission for kind of giving us a great scope to work with and asking us to assist the National Treasury and through them the National DOH with issues that were there at their highest priority, these the national health insurance and domestic resource mobilization. There's clear government and country commitment to NHI. They've been exploring it for more than 10 years. I think it came out as a political commitment, not long after the fall of the end of apartheid. And of course, the national DOH is very interested to raise adequate revenue for the health sector so they can maintain and hopefully expand their HIV/AIDS response. So in that context, our approach is we're going to give those, government agencies highly valued technical assistance on those issues that they care about. And when we bring that, then we have their attention. And now they're giving us their time, and we're working together, and it's incumbent upon us to make sure we're contributing to the PEPFAR objectives. So, we had some, we definitely have seen some progress. In 2017, the cabinet passed the National Health Insurance Policy, and they are now working on a new payment system for primary health care that includes HIV/AIDS services, and they also are implementing better, more stricter monitoring of what they call conditional grants that are focused on HIV/AIDS, and also there's grants for national health insurance. So, we find that this combination is really working, and it illustrates your earlier point, Nathan, that these internal transitions of health financing, these country-led and owned interest in changing the way they do health financing, those are opportunities for donor transition.
Mm-hmm. Yeah, great. Catherine, can you just say a little more about I think the relationship with the Social and Health Funding Office of the National Treasury was fairly unique and very important. Can you say a little bit more about our interaction with them?
You mentioned Jogan Pillay in the National Department of Health. On the Treasury side, they have a great leader named Mark Fletcher, who is often at, I think, many international events, and he's really committed. He's on the Treasury side, but he's really committed to social goals, and ready to work with the Department of Health as coming from the Treasury to make it succeed. And we made available, we were lucky to recruit a guy named Tihomir Strezrip, who was formerly the chief executive of the Croatian National Health Insurance Scheme, and later was an advisor to many countries on NHI issues. And he's been going, since 2015, he's been going pretty much every month to work inside National Treasury, and he's able to give them real-time expert advice on soup to nuts, NHI questions, complexities, decisions. And I think his real added value is he lived through it himself, and he makes them really gives them information about what are their options for all these design issues, and what are some of the mistakes other countries have made that they can avoid. And he's very Eastern European. I don't think he smiles very much, and he's got this monotone voice. And he's very serious.
We have Eastern Europeans in the room.
Yeah, you know who you are. And I think the South Africans. That he's just delivers, and he's very serious, and he's built that trust with both Treasury and DOH, and that's not easy.
Can I just throw in, I think that's a point worth emphasizing, that expertise is what engenders the trust. Yeah. And with that trust, you gain access and the ability to deliver information and services. And that expertise is so crucial. And again, when we heard this as a Croatian coming to South Africa, it was really a disconnect in a way to think about. But the reality was, it was astonishing the kind of access and acceptance and trust that he gained, really, because of his deep expertise.
And actually, Mark was on the interview committee. We interviewed, I think, 3 or 4 different candidates, on Skype or something. And we had USAID folks there, Mark Fletcher from National Treasury. So together we, figured out who would be the right fit.
Yeah, great. Thank you both. So let's jump now to Botswana, and again going, Stephen, to the level of kind of what exactly HFG did, what kinds of activities were involved, what kinds of successes in helping the transition in Botswana.
Right. Yeah. Thanks. As I mentioned in the introduction, one of the things that was challenging in Botswana was the absence of data for decision making. And really, that was one of the areas that we started to focus on right at the beginning, just to provide the Ministry of Health with the evidence that they needed as they thought through some of the issues that they had on their plate. For example, they were thinking about health insurance, but really without much information about it. They were thinking about provider payments, and so really they needed evidence on which to base some of these discussions to decide on the way forward. So that was really where we began. We helped them with the national health accounts. We worked on costing and efficiency studies. We revised their essential health package of services, and also hired an actuarial analyst to do actuarial analysis of that package. So at least now the ministry was beginning to get some real evidence to help them think through what was doable and what was not doable. We also worked with them just to, again, help them think through some of the reforms that they felt that they needed. The first one that they wanted us to help them with was the health financing strategy. Again, as I said, that did not exist there before. And that has taken, like what? How many years now? 3, 4 years to get it to where it's now ready to go to cabinet. Because the process of consultation, the process of working with stakeholders was fairly long drawn. And now that that process is coming to an end. So they have now the health financing strategy. They are also now considering moving on to a national health insurance system. And again, that is taking, actually the debates on that are just about to begin, because that's one of the key recommendations within the health financing strategy. But they can't really begin to talk much about it before that strategy has been presented to cabinet and approved. So again, there are all those preparatory, activities going on where we are helping them, for example, also with a framework for setting reference tariffs on how to reimburse providers under the insurance scheme. We are also working with them on public-private partnerships, outsourcing some of the non-clinical services at hospitals. For example, laundry. That is something that they are already outsourcing. And another area that, again, has been a big problem is the whole area of efficiency within the health sector. We help them to look at efficiency in the ART, and right now we are working with the National AIDS Coordinating Agency to look at efficiency within the HIV program. Again, because there's been so much duplication between the National AIDS Coordinating Agency and the Ministry of Health. And actually, just recently, they decided that they would fold the NACA, as it's called, into the ministry, because there was just so much going on between the two of them, and creating a lot of conflict. And really, that's one of the things that we found kind of surprising, in that the ministry has got the money to do things, but then at the same time, it's not really getting the outcomes that you would expect, when there's so much, so much resources are available, just because of the inefficiencies in the system. Or even, for example, there's really very little accountability in terms of how resources are being used at the provider level. So if once budgetary allocations are made, the money goes through the district and then to the providers, but you can't trace it really clearly from once it gets to the district, now to figure out, okay, where exactly did it go, what went to the hospitals, what went to the clinics, what went where. That kind of just becomes very diffused at that level. So, that's one of the issues that they are beginning now to address, that they have to tighten the way they track resources up to the level of the user facilities. Yeah.
So, Stephen, thank you for all that. It sounds like HFG did a lot in Botswana. Can you say more about, because I heard you say, first there's a challenge of not enough evidence, and there's definitely activities here that are trying to build up that evidence base. You have costing, you have an actuarial analysis, you have a health financing strategy maybe developed sitting above those more specific things, an efficiency study. Where do all these things go? How does that work? You have an HFG activity just producing these things, or what happens when? How did we do it, first of all? And then where do some of those products go? A costing is done. What next? How do you know that it's making an impact on transition in Botswana?
Yeah, actually, one of the best things about our working relationships with the ministry in Botswana has been that there's a health financing technical working group, which has got very broad representation both from government, from the private sector, the insurance industry. I mean, it's, everybody who has got a say in health really is there. And that is the group that has been coordinating all our work. Yeah. So whenever there's any deliverable that, comes out of the project, it goes through that committee or that working group, and they are the ones who actually validate things. They're the ones who really say that this is good enough to be released to the ministry. So that has been really one of the key, I think, success factors for our work in Botswana. That nothing goes, or nothing is complete without the say-so of the Health Financing Technical Working Group.
And does that group that group approves these things, does it also have the authority, does it have individuals on it with the power to then actually change decision-making?
Right, yeah, because very senior people from the Ministry of Health itself are part of that working group. Yeah. We also have people from the Ministry of Finance. So it's really, really very well represented. And, they are the same people who would be advocates out there, for any of the products, for any of the health financing, issues that are coming out. They themselves would become now the advocates with government and with the public as to the validity and the need for some of these reforms to happen.
Yeah, great. It's really interesting, especially I'm thinking of Kerry's example of some of the structures in South Africa that you had, even the U.S. ambassador and the deputy president having a role on a particular structure. I put that in the category of things that sometimes are boring but important, and maybe we need a catalog of the different committees and structures and their terms of reference and who do you put on them to make some of these things really, really go. Okay, thank you. I'm going to take my privilege as moderator to ask you all one last question, but I hope everyone is staying awake and not getting post-lunch sleepy. And then after I get my last question, selfishly, we'll turn it over to the audience. So please, I hope you're enjoying this and learning from it, but also thinking of what either disagreements or additional examples that you would add, and some questions. Okay, so let me switch up the order a little bit and put you on the spot again, Stephen. So for Botswana, I understand that there has been some really remarkable progress in the fight against HIV and AIDS in Botswana. Botswana went from 18,000 deaths a year in 2002 to under 4,000 in 2016. So a big disease-specific success story there. What do you think are the success stories of that impact in HIV? And the ultimate question for transition, are you confident that successes like that are going to be sustained in the future? And what makes you confident if you are?
If you remember, one thing that I mentioned at the beginning was about the government's funding for health. And I think that's one really of the most important things that has contributed to, their success in their HIV and AIDS program. That the government really has shown its commitment to financing healthcare, and even though donors are still providing quite a bit of the of funding for HIV, but the rest of the health sector, most of the funding is directly from the government. Actually, I think in 2013-14, the funding on HIV and AIDS by donors and primarily from PEPFAR, was about 38% of the response. But when you look at the overall financing of the health sector, government funded more than 70% of the total. So that's one thing. And then the other thing was just about the government's commitment to the HIV and AIDS programs and the HIV and AIDS issues. In that, I think Botswana was one of the first, if not the first, countries to provide universal ART free of charge. So again, that had a major impact on people's access to care, and made quite a big difference. And one of the things that we are learning out of all of that is really just the importance of just government commitment to the sector. And while they have still not yet got where they want to be, I think a lesson that we are also learning, because they are still doing it, is commitment to efficiency. That even though they know that they've got the funding, but they know that that funding will not last forever. Mm-hmm. And they need to begin to set up efficient systems right now. So that again is something that they're taking very seriously, and I think it will really help them in transitioning to self governance in funding the health sector.
Excellent.
Yeah.
Thank you very much. And it seems like it's a particularly strong example of, I mentioned earlier, when you're talking about replacing funding, and there being really two sources. We hear a lot about domestic resource mobilization, mm-hmm. but being already funding the health system relatively well, Botswana right. is really, it seems like, investing in the other half of that, isn't that?
That's right.
Finding the efficiencies in the system.
Mm-hmm.
Right.
Absolutely, yeah.
Okay, Catherine, kind of a big picture question. From reflecting on the HFG South Africa experience, what do you think are the main principles to take away from about transition, reflecting on South Africa?
Well, two lessons or principles I can think of is, number one, seize opportunities that matter to the country, that contribute to transition. Even if at first blush they may not be narrowly or exclusively about the particular program or health area that you're that's is intended to be transitioned. So seize those opportunities. And I think the second lesson or principle, more for us implementing partners, is work really closely with your donor client. You guys, be allies to kind of walk that tightrope of being responsive to the government, but also attending to the restrictions and goals and parameters of that donor funding. That you need to walk that path together, and I think it's incumbent upon us to be making sure our donor clients are aware of progress and incremental wins. That's beneficial for everybody. And I would just say, kind of in closing, that as you were saying, South Africa still gets quite a bit of PEPFAR funding. So the day of transition isn't even, I think, 2018 or 19 necessarily, but it's on the horizon, and there's just been very clear evidence of their commitment. Tiamir was telling me that the most recent budget allocates something like $400 million of additional funding to HIV/AIDS by 2021 fiscal year, and the bill to launch NHI was submitted to the cabinet very recently, and so I think this really shows their commitment, regardless of donor influence or pressure. So,
right, that's good news. I didn't know that last part. Thanks, Kerry. Mm-hmm. So you and I first met. I don't know if you remember this. You and I first met in August of 2003, and you were in the health office in Almaty, Kazakhstan, the regional mission of Central Asia. You've since gone on to Russia, and these were in an era when USG assistance was clearly declining in that whole region. You've served in Iraq and Afghanistan, and also, as I mentioned earlier, now 2 upper middle income countries that are clearly in that part of that transition away from external funding. So that's a lot of quite different contexts, and I imagine different transition challenges. As you think back about those different places, are there any common challenges that point out despite the differences, or any kind of broad lessons that you yourself kind of hold about transition as you think about those experiences?
Not a difficult question at all. So thank you. Yes, I remember it was August 12th, right, 2003, and you were wearing that suit. No.
Do you want to be alone?
I started in Russia, and then I went to Central Asia. But I have to. Yeah, that's okay. Yes, there are many common themes, and I think, a lot of the things that Stephen said about Botswana really resonated for me, and obviously things Catherine said. The cross-cutting theme here is we need to have host country governments, host countries leading us in our work. And I'm sure everyone in this room now has heard Administrator Mark Green say the purpose of foreign assistance is to end the need for its existence, and transition is a really timely topic, and I'm sure Kelly touched on this morning as well. This is something we always talk about when we're designing a new program. What's the exit strategy when you're doing the design at the initial phase, right? It's something we're just kind of trained that we are there to work ourselves out of a job. So I think that idea of, one, transition, but two, it has to be tailored to the country context. I have been privileged to serve in incredible places which had some similarities, but some really strong differences, and you have to respond and adapt your programming to that context. I think something, that was clear in South Africa, PEPFAR in particular, there are masses of data. We're using data constantly. We're doing analytics, but we have to do that as well with our counterparts. And so it's not in a silo or in a vacuum, but that we're engaging the host country government. And I think, for instance, in South Africa, we went through the pivot to focus for impact, and we moved out of 25 districts and focused in the 27 districts with the highest burden of HIV. And in so doing, we shared this process with the government. We, brought them along that journey with us, and they realized as well that they couldn't just focus on equity across the whole country, but they needed to really be strategic with their use of resources, because in those 27 districts, we were getting at 80% of the people living with HIV. So some of those analytics, some of those, the modeling that was done to demonstrate, again, to the government, yes, there may be a greater investment now to get to 90, but in the longer term, as you control the epidemic, you will see those benefits and efficiencies, as you've been touching on. I think another point that didn't come out in the panel that I meant to flag was the role that USAID and its partners played with private sector engagement, and even the nuances, and this has been true in almost every country I've served in, of reducing the barriers to private sector engagement from the government's point of view, right? The lack of trust, to the suspicion, even with the national health insurance in South Africa moderating so that the private sector continued to play a role. And even in some of what we did in South Africa was manage a transition where the government picked up costs for one of our implementing partners that was managing health facilities in a key area, and having the government look at the outcomes, look at the data that showed the cost efficiencies that accrued and the improved health outcomes as a result of that NGO, in this case's involvement in that service delivery, ultimately leading to a service level agreement or contracting out. I mean, the whole model in Afghanistan was about contracting out from the government to NGOs who were delivering services on the ground. So I think that's another one of the models as a donor and as a partner in these countries that USAID and the U.S. government needs to and will continue to advance, and we have many implementing partners supporting us with that. I also think, obviously, the role of domestic resource mobilization that's been touched on elsewhere today as well is crucial, and HFG played a role in helping us, as Catherine highlighted, even most recently, the near term, the middle term, and the longer term budgets, the commitment is there. And I think a lot of that is as a result of the efforts that USAID and its partners and the USG and PEPFAR made to demonstrate the benefits of those investments to the government. So I do think those are some of this. I like the seize the opportunities. I think that is crucial. But I guess fundamentally to me, the idea is that it's country-led and that we're responding to the priorities and the needs and vision of the government and working together in partnership to do that with them.
Yeah, excellent. Definitely something that carries across very different contexts. So thank you. Okay, thank you very much. I'm sure people are going to get way too bored and fall asleep if I keep asking the questions. So let's please open up now. I hope that these reflections from the panelists have been useful and interesting, and we would welcome really both comments and questions. Comments especially if you have a reflection of your own experience in transition or just a question for the panelists. Please.
Hi, Bob Fryatt from HFG. Thank you very much, particularly about South Africa. I used to work. A lot of discussion is around working with the governments and mobilizing resources. But one of the concerns that has been raised in South Africa, which I think would be even more important in other countries, is about funding to the non-state sector, the activist groups who look after the rights, particularly of people, men who have sex with men, and commercial sex workers who sometimes need that sort of international solidarity to be recognised. And I know that's a real concern in South Africa, but I'm not worried about South Africa because it has a very vibrant civil society. But in other parts of the continent, it could be a real concern. So I'd like to hear your views about that, but with transition in mind. Thank you.
Yeah, great question, and particularly relevant for vulnerable populations in countries. Should we collect maybe 2 or 3 questions, and then we'll have a round of answers? I saw a hand in the back. Sarah? Mike is coming.
Thank you very much, Sarah Bennett from Johns Hopkins School of Public Health. I had 2 questions. The first, and they're really both around the transferability of your experiences in South Africa and Botswana to other settings. So firstly, sort of other settings may be places such as Uganda, Malawi, where PEPFAR is continuing to support HIV/AIDS programming. But I wondered if you felt that there was a danger that given the more acute focus on achieving the 1990 targets and really focusing narrowly on the interventions that are going to achieve impacts, and I'm thinking both about the technical pivot as well as the geographic pivot, if there's a danger that this sort of more targeted and focused approach actually could, over a longer term, undermine some of the health system strengthening efforts that we know are so important to transition. And the second one was really to pick up on Bob's point. I mean, I think that both South Africa and Botswana have generalized epidemics. And my sense of experience in countries where there's more concentrated epidemics, if we're thinking about the Caribbean or Eastern Europe, is that it's harder in those kind of contexts to be responsive to what governments want, which I think was one of your principles, because governments don't always want to provide services to some of these more marginalized and vulnerable populations. So if you have any advice about how do you go about bringing government round to your way of thinking in those kind of contexts, I'd be really interested to hear it.
Mm-hmm. Okay, great. Okay, third question.
Afternoon. I'm Logan Brenzel with the Bill and Melinda Gates Foundation, and I work a lot with the Gavi Alliance, which is a vaccine alliance, and countries are transitioning from that alliance as well. And we tend to think of transition as having a financial component, which I think the panel well addressed. But there's 2 other things that happen when a country transitions. One is it loses funding for technical support. So one question that I have for the panel is what dialogue or provisions are there being made for ongoing technical support at the exit of donor support? And then the third dimension is kind of the programmatic and institutional capacity building issues, which I think Sarah was touching upon. And these are two particular countries that have, I think, a relatively high institutional capacity, but I'm thinking of countries like Nigeria or Laos, countries that are facing these same types of financial and programmatic transitions, and how do we, within a relatively short period of time, also build up those capacities.
Great. I think we should pause, get a few answers to the questions on the table so far, and then we'll take another round. Volunteers?
Maybe I can take
Okay.
that last question.
Great, go ahead.
Yeah, because we have experienced that.
About institutional capacity?
That's right. Yeah.
Uh-huh.
Yeah, and especially the loss of TA after the transition, because some of the work we've been doing not only in Botswana, but also, for example, in Namibia, working with the Ministry of Health to produce their health accounts, and actually also in Tanzania as well. We found that by developing capacity within the country, even if it is not in the Ministry of Health itself, that also helps to bridge that gap. When the time comes and they are not receiving direct, TA from projects like ours. So, for example, in Tanzania, the health accounts work now is supported by the University of Dar es Salaam, and I think in Kenya as well. In Namibia, although we have not worked with any of the educational institutions, but the Ministry of Health itself now has the capacity to be able to lead in the production of their health accounts, something that we would have had to do in order for them to get them. So just by building capacity within the country, whether in the Ministry of Health or in other institutions, that helps to bridge that gap.
Right. Thanks, Stephen. Do you want to?
So I actually was thinking about that last question as well, and I think South Africa originally, as the USG and PEPFAR resources were going down, the idea was we would shift to a purely technical assistance model. I also think about the examples and the experience USAID and the Global Health Bureau has had in transitioning or graduating out of other programs, and family planning in Latin America is an illustration. But part of what happened there, as opposed to a place like Russia, where we were just told to leave, right, is that there were longer-term plans put in place. So you had sort of a 5-year time horizon in which, and I think we're entering that phase, and certainly if we think about the 13 PEPFAR countries targeted for epidemic control, incredible we're even talking about it, but if they reach the 1990s, sort of what's the next phase? What's the assistance? And I presume it will be some model looking at primarily technical assistance, right, rather than direct services or, so I think it's a compelling question, but a lot of it has to go to the dialogue with the host country government, the planning for that process over time, and the need to ensure that there are either national institutions or regional institutions that have had their capacity developed to the point that they can become the providers of that technical assistance. And I also think there's now an increasing emphasis, and certainly under USAID Forward, we started prioritizing, and I think it will continue now, the work with local organizations and ensuring that they are in a place to have their capacity developed, and then that's a sustainable resource. So I think it's complex, but I think that in an era of declining resources, we have to be thinking about that and putting strategies in place now. So that was, I don't know if you wanted to touch, I could talk on some of the others, but I'll let Catherine jump in.
Go ahead, Catherine.
So that was an interesting, I think it was Sarah asked, might a intense focus on achieving 90-90 in just a few districts end up, you didn't use the word sabotage, but I mean, could it end up, not being like be helpful towards transition? And I think, one argument, I guess, put forth is that, well, if you could actually achieve those targets, you would arrest the epidemic. Like, you would be able to contain, and you would stop adding to the number of people who have a lifetime terminal illness. So that, and if you could actually contain the epidemic or contain the new infections, then that would be contributing to transition. So to the degree that we believe that achieving 90/90 is a way to contain and stop new infections, that ultimately over the long term would contribute to a donor exit strategy. But it depends a lot on how it's done. I think that what it comes down to is how it's done, and obviously if you could create a bunch of parallel systems that are 100% donor dependent, and then you abruptly pull away just as they're getting close to their targets, that does seem like a formula for potential disaster.
I just wanted to say, I was thinking in addition to the issue of private sector, the other message, I think, is that even that work on 90/90/90 involves health system strengthening. I mean, there's no question that we're doing a lot of things in South Africa that are contributing to the overall health system, and you can't completely divorce the two. And so even as you're training the health service providers, you're developing new guidelines, you're creating, strengthening the supply chain, you're still working, and the financing work. Yes, we have to link it back to the specific health outcomes and targets that we're working toward, but it's maybe less direct, but you're still strengthening the system overall. So maybe that's a bit of an optimist's perspective, but I don't think the two are completely separate.
And then there was a question about how do you get, in countries where the epidemic is limited to basically marginalized populations, how do you get and your advice is to align yourself with the government priorities, and the government couldn't care less about these people. I was going to actually call on Lisa Tarantino, who had her hand up anyway, because she's worked both in Ukraine, 3 Eastern European countries and the Caribbean that are kind of fit that profile in terms of their epidemic and the populations affected. And the fact that the NGOs are the kind of primary source of help for these populations. And somebody asked a question about, well, what happens to NGOs?
Yeah. Thanks, Catherine, for warning me ahead of time that you were going to punt that question to me. And I have the answer. It's a silver bullet. But yeah, I was actually the question I was going to ask was somewhat asked in many ways here. But in the Caribbean, we're working with on a transition program using PEPFAR funding. Global Fund is also transitioning out of many of the countries where we work. And our program there really started with a client in the Caribbean who said, help us to better understand our own experiences in other parts of the world. And we documented the experience of USAID in Eastern Europe with family planning and what are some of the lessons to be learned. And I think we, in the Caribbean, are benefiting from some of those lessons. The epidemic, even in family planning and HIV, there are some similarities in terms of cultural acceptances of certain, healthcare norms. So what are we, how are we working on that? It's a huge challenge, and it's a huge concern of the development partners in the region. I think one of the things that we are looking at are, there's a two-pronged approach. One is helping to provide the data, the policy, the advocacy tools and mechanisms for supporting some of the work that the civil society organizations do that it makes sense for the government to fund and that they can afford to fund. And in some countries, they're already doing that, for instance, in Barbados and Guyana. The other part that there are things that a government might not fund, and it might not even be their role to fund it. So at that level, we're working with some regional organizations that have a mandate, and with the local CSOs they have been supported over the years to build their capacity for different types of fundraising from people who are interested in HIV/AIDS, but also human rights and LGBT issues. So it's not going to be hundreds of millions of dollars, but maybe that's not what they need anymore because the governments are taking up some of those roles. It's a challenge. I can't say that there's a solution, and clearly there's going to be some shifts in the region. But it's something that happily there's been very clear communication, which isn't always the case, about transition. And that's been really helpful to the governments. And we have worked well, although it's always a challenge, with the Global Fund and PAHO and UNAIDS, and created together a road, I know time's up, sustainability plans, which for these small countries were really helpful. When you mentioned all these different committees and donor planning and health financing committees, these countries are kind of small, and they could use that, but in a way they just need to wrap their minds around not only DRM, but what are the other aspects of the response that they need to figure out how to transition, and that's been a really helpful tool for them. Sorry.
Great. No, excellent comments, Lisa. And I apologize for those of you that still had questions, but I'm getting clear signals that we have to wrap up. I just want to let you know that early on in the HFG project, there was a review done and a framework developed to think about particularly monitoring and evaluation of the transition. Actually, the leader of the team that did that is here with us today, Sarah Bennett, and copies of that report are over on that stage over there if you'd like to grab that. Please join me in thanking our three panelists. You guys did great. Thank you very much. And thank you all. And I was hired to say that you have a very tight 15-minute break now, which might be 14 and a half minutes now.
But dessert awaits you out there. Please feel free to speak to the panelists. If I could invite you back in here for our future trend session and closing at 2:45. Thank you so much.